Burgess for the opportunity to address the caucus today and talk about the issues of healthcare quality, health reform, and some opportunities that this forum provides to share with you some practical, real-world examples of private sector innovations that are improving the quality and affordability of care. In addition to my role with UnitedHealth Group and my prior life at the Robert Wood Johnson Foundation, I also was a practicing physician for over 20 years, practicing primary care in a variety of settings, small entrepreneurial practices, prepaid nonprofit group practices, academic practices, and for the last 6 years I've been a clinical leader at UnitedHealth Group, which is a diversified health and well-being company based outside Minneapolis, Minnesota. UnitedHealth Group, for those who aren't familiar with our enterprise, we are a diversified healthcare company that offers coordinating, financing, and health management services for over 70 million Americans. And we provide the full breadth of ancillary benefits, healthcare benefits, managed care benefits, care management services, prescription services, health IT for all the stakeholders in healthcare: patients, employers, physicians, Medicare and Medicaid programs, and state and local governments. And what I thought I would do is just share with you some of these experiences, as well as there are many other such experiences available from local, regional, and national health plans as really laboratories of innovation, of practical innovations on some of these solutions. And so I thought I'd really share both that practical perspective, but also a clinical perspective, because like Dr. Burgess and Dr. McClellan, I also come from the medical profession, and I completely agree that the role of the physician and the physician-patient relationship is really paramount and needs to be kept in mind at all times when thinking about programs and policy solutions. So, given that, we really have a tremendous opportunity to advance, as Dr. McClellan said, higher value in healthcare. There is no question that we can get better results and better outcomes from the system that we have today, given all the spending we have. And that's going to be critical if we want to make progress in promoting affordable access and addressing runaway costs in public programs for taxpayers, for employers, and for consumers. We're all paying for this one way or another, so we have to get at that. And we know we can do better. There was a landmark study in the New England Journal of Medicine in 2003 that found that patients receive indicated care and avoid inappropriate care just over half the time. So the care that we're getting is really quite suboptimal despite the hard work of physicians day in and day out. And more recent studies show we continue to have a long way to go in improving quality and safety in our nation's health system. Second, we have experience from our health plans, our care facilitation programs, our performance transparency initiatives, our data and analytic capabilities. They all point in the same direction. Higher quality care, and Mark said this as well, done right by skilled physicians and other care providers is more efficient, less costly, with fewer complications and better outcomes. In a nutshell, improving the performance of the delivery system, I do not believe, and the evidence suggests, that there is no trade-off between costs and quality. The trick, however, is in designing programs and policies that actually facilitate and ultimately achieve improved delivery system performance. And Dr. Burgess gave some examples in his introductory remarks of some things that miss the mark. So how do we do this in a meaningful, scalable way? And let me share some personal experiences from our work at UnitedHealth Group and throughout my career, some examples of approaches that work. First, UnitedHealth Group has been a leader in identifying centers of excellence for complex conditions such as transplants, congenital heart disease, complex cancer, and we collaborate with these centers, particularly generally academic medical centers, to dramatically improve outcomes such as survival rates, complication rates, transplant reject rates, and reduce costs. And the reason we're able to do this is because experienced care teams, they generally have higher volume. There's a phenomenon called practice makes perfect, and these teams are more skilled in patient selection and in delivering appropriate care. They have better outcomes, shorter hospital lengths of stay, and lower complication rates. Also, these centers of excellence, we've been able to create a national marketplace because we offer generally travel benefits to patients and their families so they can choose to go to one of these centers even if it's far away from home. These centers of excellence, by doing this, what we create is a national marketplace to create competitive dynamics where these centers compete to attract volume, and the way they compete is by trying to improve their outcomes and reduce their costs, creating a virtuous circle, if you will. And this works because in these conditions, there are agreed-to performance measures, and importantly, designed by the specialists themselves, and they get feedback on both their absolute and relative performance. And so this has been in place for several decades. It's a proven approach, and over the last few years, we've expanded that approach of measuring performance, importantly, defined by the profession itself, provide feedback to physicians, and making performance transparent to consumers. We've expanded this to what we call the bread and butter of medical care through our UnitedHealth Premium Designation Program. This program operates across over 20 specialty areas of medicine and has identified over 100,000 physicians across 132 communities in the U.S. with practice patterns consistent with evidence-based medicine consensus standards. And they also deliver care at an episode level 10 to 20% more efficient than the market average. And that efficiency from an episode point of view, that's how patients actually experience their care. This program provides both feedback to physicians so they can see how they're performing and offers transparency to consumers so they can make more informed choices. This is not a pipe dream. This is actually operating today. Another fruitful area to focus in on improving quality and cost is in the area of appropriateness of diagnostic imaging. This area of medicine, particularly the so-called high-tech area of imaging, CAT scans, PET scans, MRI, and so on, is growing at double-digit rates, and many physicians are unaware of the latest clinical evidence or guidelines. Our commercial health plan company, UnitedHealth Group, developed a collaborative project with the American College of Cardiology in one area of imaging called SPEC-MPI. We agreed to use the ACC's own appropriateness criteria to determine what percentage of studies ordered were consistent with the ACC's own guidelines. Completely voluntary for physicians, they could sign up, they could send the data directly to the ACC and have their peers review the data. Even with volunteer practices, which you would think would be providing higher quality care, about 15% of the studies performed were inconsistent with the ACC's own guidelines. Now the ACC is taking that information and augmenting its education and outreach to cardiologists around the country. This is exactly the kind of collaborative partnership between medical and specialty societies that holds great promise in the future, and we will be announcing in the near future a major initiative involving even greater collaboration with specialty societies on performance measurement and improvement. Another area we found works to improve quality and cost is in the area what is termed decision support coaching. This addresses two kinds of problems. One, helping with prevention, and second, during and through acute illness. On prevention, patients and families are busy and can neglect or overlook needed preventive services. What we have through our data systems is the ability to continually mine data through claims, pharmacy, laboratory, health risk appraisal data, and so on, and identify missed opportunities for prevention and do what is now called ping messages to both patients and their doctors. I got a message like this last year myself in a benefit statement because my son just was turning 12 years old, and it said, "Dear Dr. Sandy, you realize that your son is due for a new round of immunizations." Well, I had kind of forgotten about that, even though I knew the immunization schedule. So that's the kind of thing that we can do. On the acute illness side, anybody who's been acutely ill or trying to help a family member through these times know this is an incredibly stressful and bewildering time, yet a time when really important decisions need to be made. Should I have surgery now or wait? From whom? What procedure is best for me? What can I expect afterward? To help patients and families through these kinds of conditions, we offer what's called treatment decision support, which provides education and outreach before, through, and after major events like surgery and hospitalizations. And these programs improve satisfaction, appropriateness of care, and reduce costs, particularly by avoiding preventable hospital readmissions. Lastly, and Dr. McClellan mentions too, let me talk about incentives. The current prevailing payment systems, particularly for doctors, reward volume and intensity of services, not improvements of quality, efficiency, or outcome. And on the consumer side, many consumers have benefit designs that provide little to no incentive for engaging in health promotion, wellness, or even sticking with the plan ordered by their doctor. UnitedHealth Group has been a leader in advancing consumer benefit designs, including benefit incentives that encourage care from premium designated physicians, benefit incentives for engaging in health risk appraisal and wellness programs, and even value-based benefits for people with diabetes, which we have a whole plan called the Diabetes Health Plan, which helps diabetics achieve good diabetes control and work with physicians and other care providers. On the physician side, we develop practice rewards, which provides enhanced fees to physicians achieving high levels of quality, efficiency, and administrative HIT infrastructure. And we're early leaders in collaborating with the primary care societies to develop pilots of the patient-centered medical home, which we're now in pilot in New York, Rhode Island, Colorado, Arizona, and with others under development. And we've been innovators in exploring, and Dr. McClellan mentioned this too, episode-based payments and gain-sharing models, again, in collaboration with physicians and their societies. In conclusion, I've tried to share just a few examples of the programs and initiatives that are real-world practical solutions for both patients and doctors. Some of these have really obvious implications for public programs, for the Medicare and Medicaid, and others show the advantage and the value of active pluralistic experimentation and ongoing refinement, which is a virtue of the public sector and can be a challenge when programs and policies are too prescriptive or administered too inflexibly. Medicine is complicated, it's continually evolving, it's a mixture of art and science, and none of us should ever forget that the center of the healthcare and health policy universe is the exam room, in the hallway outside the ICU, where doctors, patients, and families are hearing hopeful news, or finding comfort out of tragedy, or making one of life's most momentous decisions. That's what really matters, and it's our responsibility to develop programs and policies that support physicians and help patients get what they need. Thank you.